Hello, everyone. Today, we will be talking about diagnosing endometrial cancer of unusual morphology. So we will try to define diagnostic clues of unusual forms. We will list the common examples. I have 5 examples here for you today. We will highlight the clinical relevance of our diagnosis and why our diagnosis can be relevant directly to how they manage their patients. And we will recognize the value and the limitations of ancillary testing, such as immunohistochemistry and molecular testing. We will review hysterectomy specimens of unusual cancer, and if every case that I will present today was a problem, at least for me. These were not easy cases. With each case, we will discuss the differential diagnosis, what are the possibilities, and why we choose one diagnosis and not the other. The molecular subtyping will be addressed with every case, and we will talk about final diagnosis formulation only. I will not talk about synoptic reports, and I will not talk about staging, because these are topics for another talk. We will discuss the complexity added when the ovary shows unexpected findings of cancer in the same case. So let us first remind ourselves that our job is to make one of these diagnoses. If you recognize endometrial cancer, we are expected to name the endometrial cancer from the list on the left. At the same time, today, we are also requested to make a diagnosis on the list from the right. So every endometrial cancer has to fit in one of 4 categories, either polymutant or MMR deficient or P53 abnormal. And if the case doesn't fit in any of these 3 categories, we will call it NSMP, or no specific molecular profile. Let us start with the first case that was 67-year-old with postmenopausal bleeding. They did an endometrial curettage, a biopsy, and the diagnosis came to us as endometrial adenocarcinoma FIGO grade 3 with extensive malignant squamous differentiation. I don't know why pathologists insist to put in their diagnosis things like squamous differentiation. Remember, this is not one of the entities that they are expecting us to diagnose. If it is squamous cell carcinoma, just call it squamous cell carcinoma. But endometrioid adenocarcinoma with squamous differentiation, that is not one of the categories recognized. It confuses the oncologist. So this is the uterus I received, and you can see here the cervical section has malignant cells. They look squamous, yes, but many of them also have glandular formation. So you can see that the stroma of the cervix is invaded by cancer. So this will qualify the patient to a stage 2 endometrial cancer. And here's the uterine section. You can see the tumor involves from the endometrium all the way to the serosa. So if the serosa is involved, then that will be stage 3. So this patient is already stage 3 endometrial cancer. Let us talk about the cell type and the morphology. How would we characterize the cell type here? We have endometrioid differentiation with cribriforming, but we also have solid areas, and the solid areas probably are the majority of the tumor. So this will qualify to endometrioid FIGO grade 3. Is this undifferentiated carcinoma? No, because we have gland formation. Is this dedifferentiated carcinoma? No, because the glands are mixed with the solid areas. In dedifferentiated carcinoma, we want to have 2 populations. Is this serous carcinoma? The answer is no, because the nuclei are round and the chromatin is open, coarse and open, and we don't have the prominent red nucleoli. So this is not serous carcinoma. Here is another section from the same tumor, just to show you the morphology. And look how the glands are mixed with the solid areas, like FIGO 3 endometrioid adenocarcinoma. They did lymphadenectomy, and you can see that the lymph node has metastasis. So this is a macrometastasis in the lymph node. MMR proteins, you can see all 4 proteins are preserved and intact. And therefore, this will be an endometrioid FIGO grade 3, MMR intact, this case will go to molecular testing. They tested the case for POLE and P53. They were wild, and therefore this case will be an example of the fourth category, the NSMP endometrial cancer. This is another case of FIGO3. I just want to share it with you, again, to show you how the glands are mixed with the solid areas in the same areas. So this will be an example of FIGO grade 3. And here is another area, another case where you have glands mixed with the solid areas. So this will be FIGO 3. Case 2 was a 71-year-old with postmenopausal bleeding. They did a biopsy, and the biopsy shows solid sheets of malignant cells. High power here again shows that the chromatin is open. Yes, some nuclei have prominent nucleoli, but generally the chromatin is open. In this case, the MMR proteins were deficient, MLH1 and PMS2 were deficient. They did P53, and you can see some cells are positive, some nuclei are negative, so this will be wild. So this will be an example of negative P53 or wild P53. ER was positive and PAX8 was positive. So this case was signed out as high-grade endometrial cancer, P53 wild. I received the hysterectomy, and you can see there's a lot of necrosis. Here's the endometrium. And again, the tumor invades all the way to the serosa. So this will be a stage 3 cancer. But I want you to look at the morphology. Sheets of malignant cells, they are not forming glands. So the sheets look very much like the previous case, but the previous case had glands. This case does not have glands. These cells look even that they could be lymphoma. Here's another section just to show a lot of necrosis, and the tumor invades all the way to the serosa. But again, I want you to look at the high power morphology of the nuclei. The nuclei are round. The chromatin is open. So this is not serous carcinoma. We don't have the red prominent nucleoli. We don't have glands, so it is not FIGO3 cancer. So this would be a good example of undifferentiated carcinoma. Undifferentiated carcinomas commonly will have neuroendocrine differentiation. So a case of undifferentiated carcinoma has to be tested for neuroendocrine differentiation. Here is a lymph node with metastasis in the lymph node. The case was positive for cytokeratin, negative for chromogranin and synaptophysin, and negative for lymphoma. So this will be an example of undifferentiated carcinoma, MMR deficient, but P53 normal. Once we say MMR deficient, so this is the second category of molecular classification. This case, this patient will be treated by a checkpoint inhibitor because MMR deficient triages the patient to checkpoint inhibitor treatment. Case number 3 was a 65-year-old with postmenopausal bleeding. Pelvic sonography showed 2.4 centimeter heterogeneous endometrial stripe. They did a biopsy, and you can see the biopsy has glands like endometrioid adenocarcinoma, but has solid sheets of malignant cells as well. The solid sheets, some of them are spindle, but you can see that we have solid sheets and glands separate from each other, and some of the cells are spindle. The pathologist did MMR, and you can see that this is deficient, MLH1, PMS2. So you know that this patient is going to receive checkpoint inhibitor. But they did P53. Again, some nuclei are positive, some nuclei are negative. So this will be wild. And therefore, this is not really serous carcinoma or not really carcinosarcoma. ER was positive, and cytokeratin was positive. Chromogranin was negative. Well, the pathologists thought that this was biphasic tumor, and it could still be carcinosarcoma, even though P53 was wild. I received the uterus, and look at the uterus here, what we have, solid sheets. Again, these are the solid sheets that we saw on the biopsy. The nuclei are round, and the chromatin is open, but right next to that, you have glands. So you have glands like FIGO1 and solid tumor sitting next to each other, separated from each other. Again, another section, I just want you to see how the solid areas, look at the solid areas on this side and the glands on this side, separated as if they are separated by a straight line. So this is the definition of dedifferentiated carcinoma, when you have solid areas and glands, but they are separate from one another. Usually these tumors are MMR deficient. And look at PAX8. PAX8 was positive in the glands, but negative in the solid areas, as if these are two clones. But they both were P53 wild. Some nuclei are positive, some nuclei are negative. So this is negative. This is wild P53. I tried NAPSIN-A for clear cell differentiation, and it was negative. And I tried SADB2, and it was positive. I really don't know what that means. SADB2 is not particularly specific for anything. So this case was signed out as dedifferentiated carcinoma, MMR deficient, P53 wild. Again, MMR deficient, this patient will receive checkpoint inhibitor. P53 wild, that means it is not carcinosarcoma and it is not serous carcinoma. Look at this case, case number 4, 77-year-old with postmenopausal bleeding. The biopsy was just signed as endometrial high-grade cancer, and probably there was a comment about P53, about everything else. I received the hysterectomy, and here is the hysterectomy. I want you to see the nuclear features in this case. The nuclei are very high-grade. This is a very high-grade tumor. But take your time. Look at the cytoplasm. See, some of the cells have clear cytoplasm. But look what the nuclei are telling you. The nuclei have prominent red nucleolus. Look at the red nucleolus. Some of the cells have this proteinaceous material that we know that we see this in clear cell carcinomas. So I think some of the nuclei, look at some of the nuclei, some of the cells have clear cytoplasm, but some of the nuclei have very prominent nucleoli. I want you to see how this is how you want your serous carcinoma to look like. Very prominent red nucleolus. It's almost like an inclusion, nuclear inclusion. Look again at this section. You have cells that look like clear cell carcinoma, but also you have cells with very prominent nucleoli, very red prominent nucleoli like serous carcinoma. And what helps me with the diagnosis of serous carcinoma is when I look next to it, I can see serous carcinoma in situ. So this is the serous carcinoma in situ, and this is the invasive serous carcinoma mixed with clear cell carcinoma. MMR, all MMR proteins are intact. So this is intact profile, but look at P53. In the in situ component, all cells are positive. This is how you want your P53 to be abnormal. So we only call P53 abnormal or positive when all cells, or at least more than 90% of cells, are positive, as in this case. When you go to the area that we called clear cell carcinoma, some nuclei are positive, some nuclei are negative, so this will be wild or negative. But when you go to the area that looked like serous carcinoma, all nuclei are positive. So you can see the two cell populations. You can see the serous population, all cells are positive for P53, and the clear cell population, some cells are positive, some cells are negative. With serous carcinoma, once we call it serous carcinoma, once we call it P53 abnormal, we have to do HER2, because this was called HER2 equivocal, 2 plus. So these patients will receive Herceptin, will receive anti-HER2 treatment. I tried NAPSIN-A to show the clear cell differentiation. As you know, NAPSIN-A gives those punctate dots, brown dots, and it shows in the clear cell component, and it was negative in the serous component. Another clear cell marker, HNF1 beta, and it was positive in all cells, including the serous and the clear cell. I don't know what to make out of that. So we call this mixed adenocarcinoma clear cell and serous, and here is the list of biomarkers as we report them. The last case was a 69-year-old with postmenopausal bleeding, and the biopsy seems like a straightforward FIGO1 endometrioid cancer. We did MMR, and it was negative MLH1, negative PMS2. So this would be an example of FIGO1 MMR deficient cancer, straightforward cancer. So we signed it out as endometrioid FIGO1 MMR deficient. Again, this will be a patient going for checkpoint inhibitor. And we know that these tumors behave a little bit aggressive. And here is the hysterectomy. I think the hysterectomy is straightforward, FIGO1, no problem. Everyone will agree that this is a FIGO1 endometrioid cancer. The surprise was in the ovary. Here's the ovary. The ovary had a tumor that looks like serous, and you think this would be a borderline serous tumor. But when you get here in this area, I think this is invasion. So this will be a good example of an previously undiagnosed low-grade serous carcinoma. That is fine. The problem was here, next to the serous carcinoma, you have tumor with cribriform round gland that looks like it could be endometrioid. So that was a problem for me, because if this was endometrial cancer metastatic to the ovary, that would be stage 3 endometrial cancer. How can we prove if this is metastatic endometrial cancer, or is this part of the ovarian tumor? In this case, the lymph nodes were positive, and I want to show you this lymph node, how problematic it was. So this lymph node here, you can see that it had metastasis from the serous carcinoma. But right next to it, here, you can see metastasis from the endometrioid carcinoma. So you can see, I don't recall seeing this before, where both the ovarian tumor and the endometrial tumor metastasized to the same lymph node. And the omentum had metastases from the ovarian serous carcinoma. So how do we sort this out? Look at the endometrial cancer. The endometrial cancer was MMR deficient, even MSH6 deficient, which is a very unusual endometrial cancer. But look at the tumor in the ovary. The serous component, it was intact, and the area that looked glandular was also intact. So I think this proves that the ovarian tumor was only low-grade serous carcinoma and has nothing to do with the endometrial cancer. The endometrial cancer was deficient, but the ovarian tumor was intact. And we knew that the endometrial cancer was P53 abnormal. It was null. This is the null pattern where no cells are positive at all. The ovarian tumor was wild, and again, that shows that these were two different tumors, and the ovarian tumor was WT1 positive. So we signed it out as endometrioid adenocarcinoma FIGO grade 1 MMR deficient, and the ovarian tumor was low-grade serous carcinoma, and the P53 mutation was shown by molecular as well. Here is another tumor that endometrium had endometrioid adenocarcinoma FIGO grade 1, no problem, but the ovary had an incidental tumor with cribriform gland that looks like metastasis from the endometrium. Again, if this was metastasis, this will be grade stage 3 endometrial cancer. How do we sort it? We sorted that by molecular testing. NGS showed different mutations in the endometrium and the ovary, and therefore the ovarian tumor was an incidental endometrioid cancer that has nothing to do with the endometrial tumor. So what we did today is we went over some unusual forms: FIGO grade 3, undifferentiated cancer, dedifferentiated cancer, mixed cancer, and endometrial cancer with ovarian tumor that was unrelated to the endometrial cancer. I thank you. And if you are interested in this topic, I recommend that you review this talk multiple times because of the very subtle features of each tumor that will probably need more than one review. Thank you.